This year's World Patient Safety Day is celebrated on the 17th of September 2025, and it's all about going back to the very beginning, with the theme Safe Care for Every Newborn and Every Child. We've prepared two special episodes for you, one on safe care of preterm babies and the other on paediatric medication safety. Hello, and welcome to Voices for Safety, a podcast from the NIHR Greater Manchester Patient Safety Research Collaboration. This is our second special episode for World Patient Safety Day, and we're going to be talking about safety for preterm babies. So I'm pleased to be having this conversation today with one of our theme leads, Nicola McIntosh, and her colleague, Julie Roberts, that we're both working together on an NIHR-funded project called PremPath, which is looking at improving safety for preterm babies. Nikki, can you introduce yourself?
Yeah, hi there. My name's Nikki McIntosh. I'm a professor in social science applied to health here at the University of Leicester. And I'm also co-theme lead for enhancing cultures of safety, which is one of the themes within the GM-PSRC.
Thank you, Nikki. And hi, Julie. Would you like to introduce yourself?
Hi, I'm Julie Roberts. I'm a research fellow at the University of Leicester working with Nikki on PremPath.
When babies are born a bit earlier than expected, that's before 37 weeks of pregnancy, they're considered premature or preterm. And that early arrival can mean that they're more likely to need extra support in a neonatal unit. The earlier they're born, the more serious potential complications can be. Prematurity remains a leading cause of death among children under 5 and can have lasting impacts on the lives of those who survive, affecting not just their health, but also placing major demands on families, education systems, and the healthcare resources. Now, during this discussion today, we are going to be talking about something called the optimisation pathway. So to start the conversation, Nikki, what is the optimisation pathway? What does that mean in terms of the care of preterm babies?
So the optimisation pathway basically brings together different types of care that has an evidence base behind it to show that it does lead to better outcomes. It consists of a number of different elements, and actually over the last couple of years, in fact, since we've been doing our research, they're adding more and more elements to that. But the basic elements that our research was looking at was firstly to look at making sure that babies are born in the right place, specific to the care that they need. And secondly, thinking about giving mothers the medication at the right time in preparation for baby's birth. Another one is around delayed cord clamping. We're talking about the cord that links the placenta to the baby and actually delaying the cutting of that so that the babies get the nutrients they need. Also making sure that babies are kept at the right temperature, not too warm, not too cold, and giving babies early breast milk where possible. So these elements all have been shown to actually improve outcomes. Not every mother needs all of those elements, so it depends of the gestation that the baby's born at, but they all have an evidence base behind them that has shown improved care.
So talking about the gestation that babies are born at, can we define what preterm babies are?
Yeah, so we normally divide that into 3 groups. So we talk about the extremely preterm, which are those babies that are born at less than 28 weeks. And then we have the very preterm, which are 28 to less than 32 weeks. And then the moderate to late preterm, which are 32 to 36 weeks. And those babies present quite differently in terms of their needs. And also looping back to what we were saying about making sure that babies are born in the right place, that they might need different settings, neonatal settings, to actually make sure they've got the care that they need.
And what would those neonatal settings, for example, be like for each of those 3 categories of preterm babies?
So we have 3 levels of support. We have what's called a NICU, which is where we have the tiny babies under 28 weeks, and they have particular sort of respiratory support, and they look after the very tiny babies. We then have the local neonatal units, which normally take babies 28 to 32 weeks, and they can give short-term intensive care support. And then we have the special care baby units, which are normally for the bigger babies over 32 weeks. And they do continuous monitoring and do some support, but they're not as intensive as some of those other units.
So you designed this project called PremPath. Can you tell us more about the different aspects of that project and what they involved?
I'm just going to set up a little bit about how this research came into being, because there has, alongside all of these elements of care, there has been quite a sophisticated audit program that has been collecting data on the delivery of these elements. And we do know that there have been improvements in the delivery of these elements in this care pathway, but there's still quite a bit of variation between delivery of some of these elements, which seem harder to get high percentage rates, and also across the country. And there wasn't really a good understanding of why that is, and also importantly, what the significance of that variation is. So the National Institute for Health Research, via their policy research programme, commissioned a call, and they particularly wanted a qualitative piece of work. So they wanted to try and get it behind the numbers to actually understand what local practices could tell us about some of that variation and the importance of it. And we were successful in sort of being appointed this work. And we were bringing our own expertise in ethnography. Julie and I work out of Sapphire, which is a group of qualitative researchers that work in applied healthcare and improvement research. And we use ethnographic methods to really understand how local practices are working, and to try and understand perhaps why some things are more problematic and difficult to implement than others. So it seemed a really good way for us to actually use our skill set.
This is the first time on this podcast that we are introducing an ethnographic study, and many people won't be familiar with what that actually means. Julie, can I come to you? What is an ethnographic study and what does it entail?
So ethnography has its roots in anthropology. So you might think of the classic ethnographers going out to faraway places or cultures very different to their own, and spending time trying to understand ways of life and perspectives on the world. But it's a method that's been adopted by researchers who study healthcare and patient safety and improvement in healthcare. So typically ethnographers would spend time in a particular healthcare setting, observing how care is being delivered, collecting documents, talking to people in the field, and collecting all of those different sources of data. And we talk about making the familiar strange. So the focus is very much on those kind of mundane, everyday, routine tasks, decisions, activities that might be taken for granted by people who live and work in those settings, but can help us try and understand what's going on there, and how well the solutions might be linking with the original problem, and how different interventions are working in local contexts.
That sounds like a lot of challenging work there, gathering all that data, carrying out observations, and actually just seeing how care is carried out in these settings. So what sort of working groups or parents or patient groups did you work with within the PremPath study?
We started with this scoping exercise at the regional level that helped us to kind of get our bearings. So I started by interviewing the people who lead the maternity and neonatal safety programs and the patient safety collaboratives, and then interviewing other kind of clinical leads and parent advocates who are really kind of regional leaders in trying to support the implementation of the pathway. And that gave us a sense of what the landscape was, who was involved in delivering this care, what the challenges were in different parts of the country. We spoke to parents as well. So we did 40 interviews with parents of preterm babies who'd been born all over England. And so I spent time in 4 hospitals in England, and we were particularly interested in how teams are working together, how decisions are made, and how parents are involved in their baby's care. And so I spent time in triage, in delivery suites and birth centres, in preterm birth clinics, in neonatal units, and various kind of staff meetings and training sessions, handovers. So each of those places gave me a little bit of the puzzle. So it's always kind of that balance of kind of trying to be in the right place at the right time, learn sort of absorbing all of that context, all of that kind of sights and sounds and busyness and complexity that people are working with, and see what we need to see while not intruding and not disrupting those everyday routines.
And I think that's a really important message, isn't it, for people listening to this podcast about research. Is we try very much not to disrupt routines and get in people's way, and actually it can be a bit of a different experience than they may be anticipating. So Julie, are you happy to share some of the key findings of your work on PremPath with us?
Yeah, absolutely. So the first one is around data and how that audit data that Nikki referred to is collected and used. And it was a huge theme in those initial interviews. And I think the research really shows the value of that data in terms of identifying areas for improvement and sort of monitoring that improvement over time and seeing if we can increase the number of eligible parents and babies who receive these interventions across the pathway. But the ethnographic data kind of shows some of the tensions around that. We kind of had questions, I guess, about the risk of focusing on getting the data right versus it actually improving care. And I think going into the setting, you really see how much work goes into constructing these data sets. That isn't simple. So that information has to flow. There are different digital systems, paper systems that don't necessarily talk to each other. So I think there's lots of issues there that we can kind of feed into those bigger national conversations about how we can maximize the benefit of digital systems for the NHS while reducing that administrative burden for staff and making it as easy as possible.
And I think we see that in many transitions of care across lots of different settings as well, how wiring up different systems so they actually speak to each other on the same level and contain the same data that we actually need in between settings. What are some of the other challenges that you identified?
So delivering this pathway requires a lot of coordination work. We saw a lot of good examples of bringing teams together, trying to build those relationships between maternity and neonatal teams. And there's quite a lot of focus on coordinating between delivery suite, where the baby's going to be born, and the neonatal unit. So to make sure both teams are ready and have capacity so that kind of happens really smoothly in terms of both mother and baby being cared for. But our study showed some gaps in that wider coordination between those two departments. So pregnant people sometimes spend a lot of time on antenatal wards. If there are a likelihood they might have a baby preterm, they might be spending time in hospital before the birth. And some of the parents we interviewed talked about how they only received information about preterm birth, about what was going to happen and about elements of the pathway all in a rush, maybe just before they gave birth. Maybe they were already in labour. So at a time when they really couldn't take that in or make use of that information. And our observations gave us some insight into how that might come about. So preterm birth is often unpredictable, and the risks to the baby change over time. And obviously, it's a really difficult time for families who might struggle to take in that information. And so there's something about the timing of that counselling, those discussions that can happen before birth. Maternity staff give some information to parents, but they're also relying on the neonatal team. They would call the neonatal team to come and talk to parents and give them more detailed information about the care for their baby and about the pathway. And it wasn't always clear whose responsibility it was within those teams, and the conversations aren't always recorded either. So there's not always a note of who's spoken to the family and what information they've been given and what have they been told about the risks at this gestation. And so it just led to a lot of uncertainty. So we're suggesting some clearer processes around that counselling of parents.
Yeah. Have you any idea what that sort of parent counselling might entail, or is that something for a future project?
I think there are processes in place for that counselling, and in some places they would use the pathway. Some clinicians use that to sort of guide their counselling, make sure they've gone through everything. I think it's more about the timing and making sure that it's updated when it needs to be. But we found kind of similar issues after the baby's born. So if a mother is spending time on the postnatal ward after she's given birth, some parents really sadly felt quite forgotten while they were in that space and their baby had been taken to the neonatal unit. They found it hard to get information about their baby, and often it's partners and fathers who are kind of bringing that information back to the postnatal ward. There's a sort of degree of flex, I guess, needed in the processes to make sure that mothers are cared for as well, and birthing parents are cared for. So I saw really nice examples in the field sometimes where perhaps a healthcare assistant would take a lunch order and then say, don't worry, I'll come and find you, whether you're here or whether you're with your baby, I'll make sure that your meal gets to you. But unfortunately, in the interviews, we learned that doesn't always happen. And we had examples of mothers who discharged themselves because it was just too difficult to get perhaps their pain medication. They didn't know when that was going to come to them on the postnatal ward and they wanted to be with their baby, or similarly meals that they found they were missing medication rounds, missing meals in order to be on the neonatal unit with their baby. Again, one of our suggestions is around paying more attention to that kind of coordination role between postnatal care and neonatal care, and thinking about who can do some of that more flexible working that can move between spaces and make sure that everybody's needs are met.
Yeah, and communicating that to the parents as well to make them feel safe in that setting as well. So when they're moving between settings.
Absolutely. And one of the things we've noted is that if that coordination isn't happening, then it does sometimes fall to both parents, to kind of fill that gap in terms of coordination and bridging and bringing that information between places.
Which must be extremely challenging at a challenging time in their lives as well. Be the guardians of that information and having the responsibility to take that with them.
Absolutely. And our research does raise questions about how the pathway might be experienced differently by different families. And there's kind of well-known issues that come up in other aspects of healthcare as well, around interpreters and digital resources and how accessible those are to everybody. And Bliss have kind of do a lot of campaign work around the financial impact of having a preterm baby, so that we know that there are financial costs to having a baby in hospital for a long time, and also loss of earnings. What we found was that there is some help with those costs, whether it's travel costs or free parking or hosting the parents' room and somewhere to get a cup of tea. But parents are often unaware of that. So those things are often quite invisible. When I'm in the hospital, they're not obvious to me. And parents in interviews told us that they often didn't find out about those for some time. Perhaps they found out about them from other parents, or, it could be a week or more before they found out about all of those things. So again, that's a really kind of simple change that might help a lot of families.
As Julie mentioned about Bliss, I just wanted to clarify that Bliss is a charity for babies born premature or sick. They champion their right to receive the best care by supporting families, campaigning for change, and enabling life-changing research. So, Julie, are there any other health disparities or inequities that you saw when carrying out your ethnographic work?
Yeah, I think our parent panel really sensitised us to some of those issues of equity in the pathway. So one of our parent members had an example of when their child was on the neonatal unit, they were offering lifts to another parent who just didn't have a car, didn't have a way of getting to the unit to spend time with their baby. And I think there is something about how the assumptions about what a family looks like and what resources they have and how they should behave that kind of underpins the pathway in different ways. So I'm thinking of a mother I met on the antenatal ward in one hospital who had been brought by ambulance, showing some signs might be going into preterm labour. Everything had settled down, so she was ready to go home. And I remember her describing to us, she didn't have a partner, she didn't have a car, she didn't have anyone who could come and get her. There are these questions about how do families manage all of the appointments, and I'm thinking of another mother who spoke to me and who had other children at home with additional needs and was really kind of torn about where to be and how to split her time. And so I think, we really need to think about our assumptions about parents and families as part of this pathway.
You mentioned that you have recommendations coming out of this based on your findings. Could you give us some insight into what those recommendations might look like?
So we worked with the Royal Colleges, with also BLIS and SANS policy unit, and the DHSC and NHS England, and others, to really try and make sure that what we're suggesting is feasible, but also is targeted at the right people. So we've identified 17 actions in total, but we've categorized those into 3. So we talk about short-term actions that we think are relatively easy to put into practice because they take little additional resource. And then the middle category are perhaps things where there needs to be a little bit more thought around organising care differently or needs additional resource. And then the last category is thinking about perhaps things that need more work, so may need further research, or actually questions that our researchers raised. And the threads through those are similar to the findings that Julie's referred to. So we've grouped them around data, equity, coordination, and respectful care and communication. So I think people hopefully can see the thread from the findings through to what we're actually recommending. Just to give you an example, that issue around preparing parents for preterm birth, one of our recommendations is not to say what should happen necessarily, but actually to suggest there needs to be much more clarity about who's doing it and what are they doing, where is it recorded. You know, these hospitals work very differently, so it's not for us to say that this is a single solution, but what we're trying to pull out is the implications and the principles that are important, and allow people to be true to those principles, but perhaps have a little bit of flex in terms of how they do it. Another recommendation is around this idea of coordination work being a really important form of structural work alongside clinical work, because in some areas we have designated people who have responsibility for coordination, e.g. around feeding, and they are able to move between units and wards and provide that support. Other people are just balancing that on top of their clinical responsibilities. And of course, clinical responsibilities are always going to trump that coordination angle. So I think it's really getting people to think about how much dedicated resource is put into that level of coordination work, which, as we know, is a really important safety indicator. And one of the other, again, quite a practical recommendations is around making sure that parents know how to access help with costs, to make that much more visible, because as Julie said, she couldn't necessarily see it where she was. So just to actually make sure parents are aware of what they're eligible for in terms of reimbursement, and also that they may be entitled to neonatal care leave and pay. So just making those things very upfront.
It sounds to me some of the main messages from this discussion have been around flexibility, communication, who carries that information to really help support everybody in this environment. What are your next steps for your team in terms of this work?
I guess for us to hopefully enable change, we've got 3 levels of action. One is around just raising awareness, which hopefully this podcast will contribute to. We're also going to make an animation to capture some of our key findings. But we also want to try and tap into some of the existing policy guidelines that are out. For instance, like BLIS has a charter, so we're thinking of maybe being able to import some changes through that. The British Association of Perinatal Medicine, BAPM, we're thinking that we could again feed into some of their guideline work. So we've identified some key stakeholders that we're hopefully going to carry on working with and think about how we can embed some of those changes. We're also thinking potentially that we could contribute to some of the e-learning resources. So I think there are various ways that we want to carry on working. Once our final report is actually accessible, that will be publicly accessible, and we will make sure we can actually share that. So for people who are interested in following the project impact, we can certainly make that available.
When that is available, we can add it to the show notes as well for this episode, so people could find it there. Nikki and Julie, we like to wrap up our sessions now with asking you what is one important learning for yourself from this project, and also why patient safety is important to you?
I think the first thing, what I've learned from this project is it's such an important area, preterm birth. It has such an impact, I think, on parents, emotionally, financially. The staff involved at all levels, from regional down to practice level, are doing amazing work. They really are. But I think doing an ethnographic study really highlights the complexity of what this is about. And I really hope that our study has tried to sort of unpack some of that nuance, which is very much about safety, is that we can introduce interventions that will have intended effects. And there's no doubt the pathway has really important benefits in terms of contributing to those outcomes.
What draws you to work in patient safety?
I think I've always been really interested in what safety means to people, and actually to try and move away from safety just being seen as a very professional, technical component. The optimization pathway is a very clinically led pathway. The elements are very clinical and quite technical. But one of our also key findings that sort of wraps around the whole project is that there is an emotional element, a relational element to optimization that actually we think should be attended to. And one of our key questions that we want to take forward for others to consider is, should we have an emotional element that should be added to the pathway that actually takes account of how parents are feeling? So I think it's a lovely example of actually that emotional element to safety, which I think is really important.
I think it is, from both the parents, the healthcare staff, but also the researchers' point of view as well. We all have to look after our own emotional element. Well, thank you both for joining us today and telling us about this amazing project that is PremPA. This is the second episode of our World Patient Safety Day specials. If you have missed out on the previous episode, please go back and listen to episode 4 on paediatric medication safety. Let's work together to ensure patient safety from the start. See you in the next episode. You've been listening to Voices for Safety, the podcast that explores the forefront of patient safety research, brought to you by the NIHR Greater Manchester Patient Safety Research Collaboration. If you enjoyed today's discussion and want to stay updated on the latest in patient safety, be sure to follow us for upcoming episodes. You can also find us on X, Blue Sky, LinkedIn, and on our website www.psrc-gm.nihr.ac.uk. Join us as we continue to uncover insights, innovations that make healthcare safer for everyone. Thank you all for listening, and we'll catch you in the next episode.